for joining today, and thanks to the CU team and Andy for having Fight CRC here. So today we are going to talk a little bit about the historical landscape around patient preference for colorectal cancer screening. We will explain patients' perceived and actual barriers and some of the challenges around screening. And we will discuss the potential benefits of considering patient preferences and integrating shared decision-making in that process. So briefly, next slide, Reese. Thanks. So a little bit about Fight CRC. So we're the leading patient empowerment and advocacy organization in the United States. And a lot of what we do is focused around advocacy work, so policy work around access to care for cancer patients and also access to screening and prevention. We also provide a lot of education to patients and also around screening prevention in general. And then we also do a fair amount of work in the research space as well. Our mission is to fight to cure colorectal cancer and to serve as relentless champions of hope for all of those affected by the disease through informed patient support, impactful policy change, and breakthrough research endeavors. Next slide. So a little background about colorectal cancer that I'm sure a lot of people on the call are familiar with. But this year, 2020, there's an expected 147,000 new cases in the United States alone, with an estimated 53,200 deaths in the same year. And 40% of cases and deaths are preventable through screening and early detection. So since the 1970s, the rates of colorectal cancer have decreased. And within the last 10 or so years, we've seen a 20% drop in the death rates during just the single decade. So there's over 1 million people right now living with colorectal cancer. And while we're seeing, this overall decline, there's a lot of significant disparities that exist, especially among certain racial and ethnic groups in the country. Next slide. So according to a few studies that Reese is going to refer to a little bit later, there seems to be a common practice of universally recommending colonoscopy. And that's because the colonoscopy is really considered the gold standard. However, this universal recommendation could reduce adherence to CRC screening overall, especially among racial and ethnic minorities. So the results of some of these studies are suggesting that patient preferences should definitely be considered when making screening recommendations. And additionally, some cancer screening decisions are considered to be preference sensitive, and so that includes colorectal cancer, where there's multiple types of screening, including stool-based tests. So it's imperative to really go over the benefits and risks with the patient to make the decision. And these decisions should include the patient's own values and preferences. So the suggestion now is that preference-sensitive cancer screenings like CRC are made individually using a process that considers the available evidence on the benefits and harms of particular options and also incorporates these values and preferences for each patient. And of course, this goes for average risk folks only, as high-risk individuals require different screening recommendations. Next slide. So over the past 3 years, Fight Colorectal Cancer has hosted more than 12 focus groups, so over 100 people total, just gathering general information about the healthcare experiences from cancer survivors and their loved ones. And what we found is that the most prevalent theme that comes up is around communication with the care team. So we found that, shared decision-making had not been part of a lot of the decision-making. A lot of providers really made those decisions on behalf of patients. There was a lack of information about options, lack of follow-up or minimal follow-up, and patients and loved ones in our focus groups often request or suggest care navigation as a way to close that gap. So while it's not specific to screening in particular, it was made really clear that a lot of these patients had experienced this with multiple aspects of their healthcare over the years. So I'm going to go ahead and turn it over to Reese to talk a little bit about the literature that discusses patient preferences and screening.
Perfect. So like Sharon just mentioned, Fight CRC has done our own work in terms of understanding the patient experience. And we have found that having patient-provider communication and the shared decision-making and care navigation is truly a top priority to our community. Um, After going through the literature, which we'll touch on more today, we realize that decision making around cancer screening can be very complex. So patients must decide whether to get screened in the first place. They must decide, which screening modality they prefer, how often to undergo screening, and when to stop screening. So this systematic literature review from the U.S. Department of Veterans Affairs from 2014 looked at over 2,300 abstracts. And what they found was that there was moderate strength evidence that shared decision-making interventions for breast, colorectal, and prostate cancer screening increased knowledge around screening. There was low evidence, however, that these interventions reduced decisional conflict and then improved clarity of values. But that goes to say, patient receptivity to shared decision-making interventions was positive. So even if shared decision-making doesn't necessarily make it easier to choose a screening method, it's important to consider and integrate when understanding patient preferences for screening. And this ensures that the patient has a say in their choice and has the necessary resources to make that decision. Like Sharon mentioned, these shared decision-making interventions could include helping patients understand their risks and benefits, clarifying what they value in their screening tests, and then also checking for patient understanding, making sure they have those tools to make the correct decision for themselves. We also did a quick literature scan of our own over the years to better understand the landscape of patient preferences for colorectal cancer screening. So the next few slides I'm going to highlight, I think, are very telling of a common theme. So this study in particular looked at 90 Black and Latino patients who had a colonoscopy, and they were educated about 4 different colorectal cancer screening tests, and then subsequently asked about their test preference, the attributes that influence that preference, and then the strength of their preference. So by far, Cologuard and colonoscopy were preferred over CT colonography and fecal immunochemical tests. And Cologuard, for those of you on the phone, was preferred at 31.1% and colonoscopy at 64%. For Cologuard, the attributes that influenced CRC screening test preference included preparation, the actual procedure, and then the benefits and limitations to the test. For colonoscopy, people indicated choosing this method for accuracy of detection, the benefits and limitations to it, and then also the frequency of the colonoscopy if their test results did come back negative. So at the end of the study, researchers concluded that to further improve CRC screening rates in these populations, patient preferences should guide the recommendations. So this next study enrolled a total of 997 participants. 58% completed the colorectal cancer screening strategy that was assigned to them or that they had chosen. Those who had been recommended colonoscopy completed screening at a much lower rate, so at 38% compared to participants who were recommended an FOBT test at 67%, or given a choice to either have an FOBT or colonoscopy percent, and that was 69% who completed screening. More notably, Latinos and Asians completed screening more often than African Americans. Non-white participants adhered more often to FOBT, and then white participants adhered more often to colonoscopy. So again, researchers from this 2012 study concluded that patient preferences should be considered when making CRC screening recommendations. In 2018, the American Cancer Society released an article titled From Guideline to Practice, New Shared Decision-Making Tools for Colorectal Cancer Screening. They brought up the point that offering too many screening options could potentially undermine decision-making, and they termed this the paradox of choice, and discussed the potential detrimental impact it could have on a patient's choice. In one study that they highlighted, patients who didn't adhere to screening reported having greater confusion about the different options that were available to them. And then in a separate large randomized control trial that they looked at, it showed lower rates of completing screening when only a colonoscopy was offered to the patient compared to either offering them an FOBT test or a choice to have a colonoscopy or an FOBT. So again, the ACS suggests that the patients have the opportunity to select either a visual examination, so in this case, a colonoscopy, a CT, or a flexible SIG, or have a high sensitivity stool-based test based on access to and availability of test options. So this kind of goes back to that point about shared decision-making. Its importance in providing information to help patients understand their options, presenting the risks and benefits of those options, checking them for understanding, and truly understanding their values in making a decision. Here we highlighted several older studies that ranged from 2007 to 2009, showing differences in preference with no clear one-size-fits-all approach. In the first study on the left, it was a diverse sample of over 300 adults who were given information side by side of FOBT and colonoscopy. 53% preferred FOBT, and almost half felt very strongly about that preference. In this 2008 study, over 200 patients across 4 different health centers rated their preferences as well, and you can see 37% preferred colonoscopy compared to 31% preferred FOBT. And then in this next study from 2009, over 2,000 VA patients were given brief descriptions of colonoscopy and FOBT. 37% had a preference for colonoscopy and 29% preferred FOBT. So it's really important to understand, based on this landscape, what works for one patient may not work for another. The last study I want to highlight reviews vulnerable populations for colorectal cancer screening, and this included racial and ethnic minorities, low-income groups, veterans, and rural populations. And they found that there is a wide spectrum of colorectal cancer screening preferences within these vulnerable populations. They highlighted that more decision aids and discrete choices are needed to get a more nuanced understanding about how specific populations weigh particular features, or, like we mentioned, attributes to these screening methods. And then finally, again, no test modality was overwhelmingly supported by all these subpopulations within the vulnerable population they reviewed. Important features to this group included accuracy, sensitivity, cost, and convenience. And then again, in addition to that, shared decision making. So the takeaway from all of this is that, there really are these differences in patient preferences depending on age, sex, race, socioeconomic status, vulnerable populations, geography, and so forth. But sort of tying this back to the beginning, patients really do value this shared decision making, being educated about their options, having patient navigation and care coordination in their screening process, and the literature overwhelmingly supports that patients do need to be involved in these screening decisions. We always say that the best test is the test that gets done, and we hear this repeatedly all the time. So taking into account patient preferences is truly necessary to do so. So now that you are all very well versed on the literature, we wanted to pull in Winora Johnson, who's been at the front lines of colorectal cancer screening, to share her experience. Winora is a Fight Colorectal Cancer research advocate and has been involved in Fight CRC for the last 3 or 4 years now. She's a stage 3B colon cancer survivor with Lynch syndrome and has been truly a fierce voice for others affected by colorectal cancer. So Winora, I will now hand it over to you to introduce yourself and share your experience with screening.
Oh, thank you, Reese, and hopefully everyone can hear me.
Yes.
Yeah, you can hear me? Great. Thank you again for that introduction. And Reese, like you, I'm in agreement with the importance of the patient preference and involvement. For those of you on the line, again, my name is Winora Johnson. I am a 3-time cancer survivor, my initial cancer being colon cancer, followed by endometrial and basal cell carcinoma. This, of course, led to a Lynch syndrome diagnosis and further treatment from that. I'm also a Navy veteran and now a going on 6-year Fight CRC volunteer research advocate. I'd like to say I am also a fit test enthusiast. And for me, what exactly does that mean? It means for me, if I had not taken the suggested fit test prescribed by my primary doctor, I would not be here today. And I don't say that lightly, because for me, it was imperative that I take yearly checkups, especially when you're in the military you are subjected to yearly physicals, and then I also did yearly physicals with my primary care physician. However, in 2011, my primary care physician decided to add an additional regimen to my normal routine, and that was a fit test. And at first, I kind of set it to the side because I really didn't think it was imperative. I figured I was healthy. I had been healthy for the past several years. Why am I doing this crazy test? So I actually set it to the side. After that, a nurse called me and reminded me that I needed to turn it in, and I was compliant this time and turned it in. Now, after I turned it in, the results did come back with microscopic blood in my stool, which promptly led to a colonoscopy. And from the colonoscopy, it actually led to surgery, and then waking up from the surgery with a diagnosis of being stage 3B, having stage 3B colon cancer. I consider myself really, really lucky and fortunate because this simple stool kit actually saved my life. And if I could further elaborate on why I feel that way, is because at the time I was switching through various insurance because of different jobs, and the one job didn't offer the best insurance options at the time. So to actually have a colonoscopy, I was coming out of pocket $300 versus no additional cost associated with it. So for me, it was just really, really looking at which test was more feasible to me at the time. And I have to say that the FIT test really was imperative with saving my life. It directed me through the route that I needed to take, with following up with colonoscopies and eventually surgery and then treatment with chemo. So Reese, if you wanted to ask me any of the questions in case I've left something out, please feel free to chime in.
Great. No, and I think we can probably also, if anyone has specific questions for Winora, to use the chat. But I guess, Winora, what we'll have you do is this next part of the presentation, I guess maybe just think through a little bit how it resonates with you. And then towards the end, we'll punt to you to get kind of your feedback and general impression of this next part of the presentation. But thank you so much for sharing your story. That was very insightful.
Thank you.
Sorry, I was on mute there. Recently, Fight CRC put out a short survey. Thank you, Winora. Sorry, that was an amazing story, and thank you for coming on and sharing your story for everyone. The next section, we're going to talk a little bit about a survey that Fight CRC had put out recently to learn more about specifics for colorectal cancer screening. We had just over 20 people answer, so this is really just a snapshot, and I'll go through some of our results. So in this current slide, we asked, did your healthcare provider share with you the menu of options for colorectal cancer screening? Overwhelmingly, the answer was no. We see that a majority of people were not given an option or a detailed description to learn about other types of screening. And this is really reflective of the common practice of universally recommending colonoscopy, which actually all of the participants of this survey did have a colonoscopy. So we can go ahead and move to the next slide. So this shows kind of the breakdown of those 20 people. Everyone had a colonoscopy. Oh, sorry, looks like the numbers are a little bit off on the bottoms. 100% of people had the colonoscopy. But we had 5 people had a flex sig, 4 completed a FIT test, and 2 FOBT, and 3 FIT DNA. Next slide. So we asked folks that did have the FIT or FOBT or the FIT DNA if their healthcare provider shared information with them about the need to have these tests regularly to be effective. We see that not all healthcare providers were clear or checked for patient understanding regarding the frequency of stool tests to be considered a good test. Next slide. So did your healthcare provider tell you if you were average or high risk for CRC? This question got a bit complicated because we had a few folks that mentioned that they went in for a diagnostic test versus a screening test. So that covers our other section of the pie chart. But also a majority of people said that they were not told one way or another what their risk for colorectal cancer were prior to their screening. And next slide. So these are just some quotes that we had come in about barriers to stool-based tests. Folks said that they felt embarrassed to send their stool sample to the lab. They didn't want to handle their stool. This person said, I thought I would have to touch it. And another person said, I didn't understand why this test was being offered to me. So those were some barriers that we saw come through. In terms of what people did not like about the stool test, we heard they gave me a test that was considered outdated, but I was not educated to know the difference. Another person said that the test was not explained well, and another person was given an FOBT that came back negative, and they were diagnosed later at stage 4. They had a new primary care offer a fit, and they said it was not appropriate for someone with their own health history. So it looks like they were given a test. This person would now have been considered high risk, and therefore offered a different test than what they were offered. And then what do you like about a stool-based test? These were really straightforward responses. You could do it from home. I did it at home with no prep. It was very simple, easy to mail off. Next slide. So of course, we asked everyone if they have talked to others about screening once they had received the screening themselves. Everyone said yes. So we thought this was a really interesting and also important slide. There's some stigma around colorectal cancer screening. So we thought that it was a good sign that once people are screened, that they're starting to spread the message to their family and friends, ideally hoping to destigmatize the screening and also to support others to ensure that they're getting screened as well. Reese, I'll put to you.
Perfect. So I think, to wrap up everything that Sharyn and I have highlighted is, why consider the patient preferences? There's of course benefits to improving health outcomes, and there are a wide spectrum of CRC screening preferences within vulnerable populations. Even within the slides that Sharyn just highlighted, there's a gamut of different screening modalities that people have experienced and different fears and barriers as well as opportunities. So some of our final takeaway messages from this is always include the patient in shared decision-making, provide ample information about the pros and cons of each screening method, and then always check for patient understanding and to ensure that the patients are able to make the best screening decision for themselves and have that shared decision-making capability. So before we take questions, I did want to punt back to Honora and just see what your general thoughts were, after seeing these results from the survey that we distributed to our community, if anything resonated for you or if anything stuck out.
Thanks, Reese. I think for me, the barriers to stool-based tests, the barriers to stool-based tests, I could resonate very well with feeling embarrassed to send a sample into the lab. It just felt so private. So once getting over that, and when I look back in retrospect, how imperative it was to further diagnosing me, we really have to overcome those fears of embarrassment. So I could really relate to the stool-based test there, and then the positive side of it, like you could do it from the privacy of your home, and the directions on it could have been maybe a little bit better for some of us who do those standard kits, but overall, I'm in agreement with the items that were presented here from the survey.
And so, Honora, what, I guess, I know the majority of individuals on here are not patients, but I guess from the patient perspective, what is one piece of advice you would give the patient population if they are experiencing these barriers or have fears around initiating that screening test?
That they really need to have a in-depth conversation with their provider. Ask them questions and suggestions about their care and his or her suggestion as to why the doctor suggested a particular test. That can probably maybe alleviate some concerns or embarrassing things such as sending your sample in. So just really having an in-depth conversation with that provider really helps. And that's what I think.
That's great. And one more thing I wanted to ask you before we move into the Q&A, because I see some good questions coming in. Being diagnosed under 50 yourself, what are some ways that you would, I guess, encourage like that younger population to get screened?
I know sometimes with younger populations, and that's why I mentioned a little bit in when it was my time to talk a little bit about me, that sometimes cost factor can be a decision factor when it comes to our health. And we don't want to cheat ourselves out of an opportunity to have a healthy, existence. And if it's something that the doctor prescribes or so that we really need to do it, I think maybe what could help in this aspect is, especially when talking to those under the age of 45, is having ready available literature, especially like the kind that Fight CRC provides for those who may have questions just about the general procedure itself and why should they? Because more and more people are being, diagnosed at a younger age and are dying from it unnecessarily. So those are just pivotal, important things for me, is just having the literature readily available and having that talk with that provider.
That's great. Thank you so much. And I really appreciate your insight as we put together this presentation and whatnot. So I think with that, we are through with our slides and are open to taking questions now.
So I guess I can see some of the questions that came through. So we had a question that states, what advice could you provide navigators when a patient is diagnosed with colon cancer? And that's a great question. Yeah, so I mean, obviously there's a lot that's going on in the patient's mind. And what we hear so many times is that a lot of information is given in a short amount of time. And that makes it really hard for the patient to understand and digest everything that's coming at them. So I think an important role of a navigator would be really to check that patient understanding. So, slow it down, ask questions, make sure that they're absorbing the information that's being delivered. And if they need to take some time to process, like that's okay also. We hear a lot that patients feel rushed into making treatment decisions and then miss out on opportunities for second opinion or, or other treatment options that could have been explored. So really just ensuring that the patient is understanding the diagnosis is important. Slowing down, checking for patient understanding, and just really being there to make sure that the process goes as smooth as possible for the patient, and not ensuring that they're not feeling rushed into anything when they're not quite ready.
And I think one thing I would add on to that, and I think, Amy, this kind of also addresses the same question, is that meeting the patient where they're at, and then in terms of if their screening does lead to a diagnosis, ensuring that they're getting their patient education materials and the resources and support at the time of diagnosis relevant to their disease state versus, months or weeks down the line. Sharyn and I have heard anecdotally stories about patients receiving breast cancer materials at the time of their colorectal cancer diagnosis, So I think, you know, as a navigator, just being really in tune with the patient and where they're at that time of diagnosis. Another thing that we've heard anecdotally is helping support them and their caregivers at the time. So a lot of times patients are very much, you know, in their own head when they are diagnosed. So making sure that this information is communicated to a family member or to someone else at that point could also, I think, educate and support them in that moment. Question.
Reese and Sharyn, can you actually talk to folks a little bit about the Fight CRC resources such as Guide in the Fight and how some of those things can really be helpful for newly diagnosed patients?
Sure. So Fight CRC has a whole library of resources that are great for patients to have at the time of diagnosis and beyond into survivorship. And so Your Guide in the Fight is a resource. It's a 3-part book that walks a late stage patient through understanding their diagnosis, who's on their treatment team, what questions to ask. It walks them through all of the current standard of care and different treatment options and clinical trial information. We also have in that resource information on managing side effects, survivorship care. There's a section for caregivers and loved ones. It's a really comprehensive resource that you can download for free off of our website, or you can order a hard copy to be delivered to your home or to your cancer center as well. So that's Your Guide in the Fight. That's probably our flagship resource, and it's specifically geared towards stage 3 and stage 4 patients. We also have smaller resources that are topic specific that could be really for any stage colorectal cancer patient. So we have resources that discuss genetics and hereditary colorectal cancer. We have side effect management, clinical trials. We have a whole library. So if you go to fightcrc.org, you can search our library there. I also really want to highlight our screening resource, which is a small pamphlet that talks about all things colorectal cancer screening. So from average risk to high risk, what does all of that mean? What are the different screening options available, and what kind of frequency do they require? Do they require PrEP or not? Also in that resource, we have patient testimonials, so talking about their experience with screening. We have a couple of GIs who provide insight as well. So it's a really, really comprehensive screening resource, also available for free. You can order copies in bulk for the patients that you see. And yeah, we've got really wonderful feedback. It's being translated currently into Spanish. So hopefully that we'll get that out very soon as well. So all of that can be found at fightcrc.org. And of course, if anyone has any specific questions about our resource, I'd be more than happy to answer any of those questions.
Hi, this is Laura. If I can just add one thing too, I really appreciate it, the comment about the navigator and appreciating that sometimes having another voice to help you there when you are given a diagnosis, and the importance of that navigator's empathy and understanding of what's taking place it goes a long way too. We remember only after the fact, after everything was calmed down, it's like, wow, that person really provided me the best information available and was there when I needed them. So it's just such an important role, and hope that more patients have navigators or people that assist them when they are given a diagnosis of cancer.
Okay, if there's any final questions, again, we welcome you to put it in the chat, or at this point, you are welcome to unmute yourself if you would like to ask a question directly. And then as well, Elsa has put the link for today's evaluation of the webinar in the chat. So if you would please take a moment to go ahead and click that link and answer just a couple of questions about today's presentation, we would appreciate that. So we'll go ahead and give it just another few seconds here to see if any more questions pop up. In the meantime, Reese or Sharyn or Winora, if you have any final thoughts, we welcome those.
Thank you both. Thank you all for allowing us this opportunity to present to the group. I think, you know, having the patient experience is so valuable, and so really appreciate you including this topic in your webinar series.
I'd also like to harmonize in on that too. That it's imperative that patients have knowledge about everything out there, and Fight CRC is doing just such a wonderful job of providing the information needed for all of us to make well-informed decisions. And it's just my first go-to as I've experienced additional cancers. So I really appreciate Fight CRC doing what they're doing and getting the appropriate literature out there for those.
Wonderful. Thank you so much for being able to share your perspective today. We really appreciate having you. And Reese and Sharyn, thank you so much for providing all the information that you did. We'll go ahead and close out. Again, that evaluation is in the chat, so please take a moment to complete that. And with that, just thank you all so much for taking your time today. We appreciate all of you, and feel free to reach out with any questions that maybe you think of later on, and we'll go ahead and reach out to our presenters and see if we can get all those answered for you. So thank you all very much, and we hope you have a wonderful rest of your day.
Great, thank you.